Hi, Mike Gibson coming to you live from ACC 2023. We're talking about the FLAME study, and I'm joined by Giri. Welcome.
Good to see you,
and joined by Mitchell Silver. Welcome, Mitch.
Good to see you.
Where are we at? What's the background?
So the issue with pulmonary embolism is the following. We have two main goals in how we're trying to improve care in acute PE. One is an obvious one. We want to reduce short-term mortality in this disease process. And two is a little bit more ambitious endeavor over time. We're looking to improve quality of life in these patients in the long term, especially from an exertional capacity standpoint. The issue with point one, improving short-term mortality, is an interesting one. As it turns out, a lot of the short-term mortality in PE patients is driven by a subset of the patients. These are the patients who come in, probably not surprisingly, the sickest. They have low blood pressures, they are in shock, they might be on pressors. Even worse cases, they actually may be having a cardiac arrest with PE. And what do we know about those patients? Well, it turns out studies around this area have not been that rigorous and have not been that numerous. In fact, the best multi-center evidence in this area comes from the International Cooperative Pulmonary Embolism Registry, and it was published nearly 20 years ago. So it really was a study of patients in Europe in the 1990s.
Yeah.
Now, a lot has changed about PE since the 1990s. With this in mind, a few years ago, a group of us tried to lay out what are some research priorities for maybe moving the field forward in massive high-risk PE, this very high-risk population that's dying. And what we learned is that it's actually quite difficult, at least as an initial step, given where the state of the evidence is, to just say, oh, just run a randomized trial and everything will be solved. We kind of don't even have the infrastructure to properly do that yet. But we know we do need good data, and we need good prospective data to push the field forward. We tried to lay out a few principles of how we might obtain that data, and that included trying to kind of find some historical benchmarks that made sense in terms of complications, and then trying to also think through how do we enroll patients with PE who are being treated with novel therapies and even novel interventional therapies, and then how do we also capture those patients who don't get treated with those therapies so that we at least understand the whole scope of the problem. And that's kind of what the background of where we stood with that led us to thinking about the FLAME trial, which Mitch led.
Great. Thanks, Jay, and thanks, Mike, for this opportunity. So that was a great segue into how we designed the FLAME trial. So by nature of this very sick population of patients, we recognize the gold standard is an RCT. Couldn't do that with this group of patients. They're too sick. It's not that common. It's like a trauma study. You just can't randomize those patients. But on the heels of a recommendation that Jay's group was part of from AHA, they said, we need good quality data for this high-risk group of PE patients. Do a meta-analysis, come up with what you think is a robust outcome measure. And that's what we did. We published a meta-analysis and came out with a performance goal, if you will. And in the performance goal, we felt 32% of patients would hit this outcome, which we made a composite of in-hospital mortality, major bleeding, a bailout to an alternate thrombus removal strategy. And that's sort of the protocol that we followed. But what was fascinating in this high-risk group of patients, when we teased out in-hospital mortality, it's the first study ever to show actual mortality benefit. To the extent 1.9% mortality in the FlowTriever group, the expected mortality was about 28% based on the meta-analysis, and the other group that received everything but FlowTriever was about 28%. So very impactful on in-hospital mortality. And interestingly, the patients that had advanced shock were actually more common in what we called the context arm, the comparator group, but in the Inari arm, the FlowTriever arm, zero mortality in that group of advanced shock patients, where in the advanced shock patients in the other group, the context arm, it was about 46% actually, 46%. So I think the message is, and Jay and I feel about this the same, you have to have a really good care pathway where you have a team approach like the PERT consortium puts forth that are dedicated doctors that understand pulmonary embolus treatments, understand the best treatment for that particular patient that comes in. And in the high-risk patient, it's probably rapid triage to the cath lab where there's a team that has advanced care capabilities, rapid onset of ECMO if needed, and do a large bore aspiration where you rapidly unload the right ventricle. And I think that's what drove the mortality benefit. As cardiologists, we know what causes death in PE: right heart failure.
Absolutely. Well, great. Thanks for sharing with us. And thanks to all of you for joining us here live from ACC 2023.